Welcome to the SIBO Doctor podcast with Dr. Narala Jacobi, a US-trained naturopathic physician and medical director of the SIBO Doctor, an online education resource for practitioners. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. Head over to thesibodoctor.com where you can learn everything about SIBO from the basics to advanced treatments. You can also join in the conversation on the SIBO Doctor Practitioner Forum Facebook group. If you're a patient, please note this information is not intended to diagnose or treat medical conditions. Please ask your doctor before initiating any new treatments. We welcome you to head over to the SIBO Lifestyle Facebook group, where we post frequent tips and videos to help you on the road to gut health recovery. And now, over to Dr. Jacobi and the SIBO Doctor podcast.
Welcome, SIBO practitioners, and all those listening in. I know it's not just SIBO practitioners, there's a lot of patients also listening in. With me today, I have the great pleasure to interview Dr. Megan Taylor, who practices primary care in naturopathic gastroenterology in Seattle, and mainly for adults and children with digestive complaints, allergies, and autoimmune disease. A lot of her information you'll find in the show notes, but we'll talk about that at the end as well. She earned her doctorate in naturopathic medicine from National University of Natural Medicine in Portland, Oregon, graduating with honors. She completed 2 years of postgraduate residency training in primary care and naturopathic gastroenterology under the mentorship of Sandberg-Lewis and Dr. Allison Siebecker, Dr. Stephen Sandberg-Lewis. She has advanced training in the diagnosis and treatment of specific conditions such as GERD or GORD, as we call it here in Australia, gastritis, inflammatory bowel disease, including microscopic colitis, gallbladder and liver disorders, functional abdominal pain, functional dyspepsia, visceral hypersensitivity, irritable bowel syndrome, and SIBO. Very, very good. And additionally, Dr. Taylor is also the vice president of the Gastro ANP, which is a fabulous organization. And I'll just spend a minute talking about that. Do you want to just introduce us to this organization, Megan? And welcome to the show, by the way. Sorry.
Thank you. I'm so happy to be here. And thank you for inviting me. It's wonderful. So the Gastro ANP is a specialty organization. It's actually been around for about 5 or 6 years. It was started by some of our leaders in our field in Portland, actually. And they really, in the last year and a half or so, we've transitioned boards, and Joshua Goldenberg, who's out in Colorado, myself, Mark Davis, Adam Sanford down in California, a couple other folks are participating in really trying to grow the organization. We're a specialty organization, similar to Onc ANP and Peds ANP and Endo ANP. We're really looking to working on a few goals. Big time is to provide really quality education and mentorship to graduates in naturopathy and gastroenterology specifically, and get people really up to speed on how to diagnose and manage certain conditions. And then we're also working on a fellowship track. That's one of our big pushes is to get a specialty certification for folks who have experience and are wanting to sit for a board specifically in gastroenterology, to have kind of just continue to raise the bar on the quality of the gastroenterology care that we're giving our patients. So it's really exciting. We're a really dynamic organization. We're always looking for feedback. We're always looking for volunteers. Our website just got a massive remake, and so it is actually running well. It's beautiful, and we actually have an upcoming conference that we're promoting in October in Portland. We're partnering with the National College of Natural Medicine, National University, and UNM to host their annual gastroenterology conference. It's going to be 2 days. We've got an incredible lineup of speakers, many of the folks you've interviewed on this show. And the day before, the Friday before, we're going to be doing a pre-con, and it's going to have all these hands-on workshops, including, I know you're going to be doing a hands-on workshop with Dr. Sandberg-Lewis later this year. He's going to be there to help us do that work. and a number of other folks just really trying to build those hands-on skills in that. So people can head to our website, gastroanp.org, and just check it out, see what we have to offer, and join.
Yeah, so we should probably explain the acronym. Gastro ANP stands for Gastroenterology Association of Naturopathic Physicians. So all of you NDs out there who are licensed naturopathic physicians in the US, please check out Gastro ANP, great organization. Okay, so we are talking about digestive disorders in children. And you have a lot of experience, don't you, Megan, with kids and tummy aches and SIBO and IBS and things like that. So, I wanted to kind of dive right into that because there's a lot of folks who write to us at the SIBO doctor. They don't know how to treat children with digestive disorders. So maybe just kind of start with, what do you see most often in your practice in children with digestive disorders?
Yeah, great question. Kids are definitely a population that I gravitated towards really quickly while I was in school, in part because I had the good fortune of working with Dr. Sandberg-Lewis, and he's amazing with kids. And I saw just some incredible results working with children, and was really empowered to work with this special patient population. Definitely what walks through the door most commonly when we're talking about digestive complaints are chronic stomach aches and constipation. And often those are the biggest challenges, and there's very little offered in the conventional medical model for these kids beyond osmotic laxatives and maybe some, pharmaceuticals, and not a whole lot else. And functional diagnoses are often given. So functional abdominal pain is a real common one. A lot of these kiddos aren't diagnosed with IBS really young, but a functional abdominal pain diagnosis comes often with them. And then we get all like the additional, symptoms that arise outside of their gastrointestinal tract as a result of gastrointestinal dysfunction. We see rashes, we see mood changes, we see all sorts of things that go along with it. But those are definitely the most common by far.
Do you do SIBO testing on these kids, and how often do you? Because I think, with SIBO, it's sort of like you're not going to see as much, perhaps, of the motility issues that we would normally see in an adult that's traveled overseas and has had multiple rounds of gastroenteritis, etc., that really damages the migrating motor complex. So do you see, I do see, I often consult with practitioners that show me the breath tests before and after in the kids that they've treated. And certainly they had it. Just yesterday, I was consulting with somebody who had a child with eczema, practitioner, and I think it was a 4-year-old, and she had a really dramatic result with breath testing and had before and after. It wasn't resolved at all by any means, but it made a big difference. But a 4-year-old with like massive fermentation in the upper gut. So,
really,
how often
really
do you see that?
Right?
Yeah.
Yeah. I see, I do see a fair amount of SIBO. That's often what people are coming to me for, because they know of me or have heard about me in the SIBO world. So they're often coming to me for SIBO. And the first thing we're usually doing in their kids, and the first thing we're usually trying to do is tease out what's really going on. Because as you know, as your listeners know, SIBO, the symptoms associated with SIBO are so incredibly varied. And there are many other things that can cause those symptoms. And you're absolutely right. Kids, because they have less life lived up until the point, they're less likely to come into contact with some of the risk factors, some of the things that put them at risk for developing SIBO, just because they haven't had as much life lived yet. And so I really get very curious about SIBO in certain patient populations. I get really curious about it in kiddos who've had a ton of antibiotic use, who've had early intervention. So great examples are, of course, kids. I had a case early in my career with a little guy who had a rare cancer with radiation and chemotherapy as a result when he was 3. And that definitely set him up, right, for some immune suppression, potential for adhesions, and potential for developing SIBO. So that was really obvious to me. Any kid with chronic immune issues, it seems like we just are always coming down with the latest and greatest. thing, an infection, that is a patient population I'm really curious about. And then always, as with our adult population, I'm always looking for kids who have got a lot of bloating, especially a lot of bloating in the postprandially in the presence of loose stools. And this is where I get a little bit, I think a lot of us can jump the gun a little bit on testing for SIBO, especially in the pediatric population. And I've seen this a number of times where kids are constipated and nobody realizes that they're constipated. They just are bloated. So the issue is they come in, they're bloated. They're always bloated. They have stomach aches. They come in and we start teasing out, their symptoms, and we're realizing that even though they're having bowel movements every day, they're not fully evacuating their colon. And so they're actually retaining some stool. And it's my belief, and I haven't been able to find any research on this, but I have had a couple gastroenterologists sort of confirm this with me, that it seems to be that if we can address the constipation, and I've seen this a ton in clinical practice, really get the large bowel moving effectively, that the SIBO-y symptoms, that bloating and abdominal pain that can come with it, kind of go away. Now, have I had pre and post testing to really show this? I've had it in a few adults, but not in kiddos. So I don't have that to sort of prove the point, or at least try to illustrate the point. But that has to be the first thing that, in my opinion, is always ruled out when I have a kid walk in the door where they suspect SIBO, or I have SIBO's on my list of differentials, is that I'm really making sure that the large bowel is functioning optimally. And there's some great resources out there for helping parents understand what it means for kids to have, they'll be like, oh no, they go poop every single day. But this whole concept of retaining stool in the colon and how that really is a thing that happens in adults and kids. But there's It's No Accident is a website by a doctor who's a pediatric urologist in the States. And he got into this whole thing about chronic constipation when he was working on kids with just continual bedwetting. That was the big issue he got into. And he realized it was coming back to constipation. And so he got really good at recognizing constipation in kids that weren't presenting as constipated kids. And he has great resources online for kids and parents on pooping regularly, what that looks like, how to help do it, all these things. So I often point parents in that direction. So that's generally what I'm looking for. I'm always making sure to rule that out first. And then we dive in, and absolutely I will do breath testing if I feel like there's big risk factors. I guess I didn't mention a couple other things. Obviously, failure to thrive or unexplained nutritional deficiencies, big time in kids. And then any kids who had anatomical abnormalities when they were born, or there's a family history of that, right? Kids with malrotation early in life, you can just kind of assume, right? There's going to be likely dysfunction of the small intestine. So I throw that group in there as well, because I'm likely to test for.
Great points. And, I often say, I've said this before on the show, especially with children respond normally very quickly to our medicines, to natural medicines. I've been in practice for over 20 years now, and I have seen sort of a shift a little bit in that kids are also starting to be a little bit more difficult or less quickly responsive. And I think the reason for that is everybody just comes preloaded now with all sorts of things and microbiome dysfunction. But getting back to your other point, I do think that's a really valid point, that you just sort of look at what the issue is and kind of reason it through and address it and see if the symptom resolves, rather than doing a lot of testing for SIBO. I completely concur, because I do have some young patients who very clearly in my book are either, they have a lot of fecal retention, they do incomplete voiding. And we do, sometimes I just do bitters with these kids. I sound like a broken record always on the show, because it's truly my favorite.
Yeah,
it's kids very often, in my experience, especially when there's an allergic component, like asthma or food allergies, I often think of what's happening. Why is that happening? Are they just not digesting their food right? And I can't remember who said it, if it was Bill Mitchell or Dr. Bastier or any of these giants that talked about the hypochlorhydria in these patient population. And I just wondered, how often do you come across that, where where that's really the underlying problem and everything is just a consequence of that problem?
That's a great question. I want to say one thing to kind of our last point, and then I'll answer that question in part just for your listenership that are practitioners. There's an easy way to tell if kids are retaining stool, and that's an abdominal plain film. I know none of us want to prescribe more like radiation to our pediatric patients necessarily, but we know that our radiology field has greatly advanced at very low doses, and that can be a quick, easy confirmation that there's fecal retention happening in a kid where you really suspect it. So just throw that out there as an option if you're in a state where you can order something like that.
Well, here in Australia, we can't. Yeah, we're in Australia. We have to just use our hands to palpate.
I have been really impressed. So there's a study that was looking at. It was like I got this from that Dr. Podge's website. A study that looked at our capacity to actually palpate retained stool is actually quite low. Like our sensitivity as providers, and it's just so disappointing. I feel like I get so disappointed with that because I love our physical exam and I think it's so valuable. But it's good to remember. You can still.
And I mean, by symptoms, a little bit of physical exams, and I'm always promoting physical exams because it's just so important to do and so difficult when you do telemedicine. That's the one thing.
Oh, it's so challenging, right? Yeah. But getting to your next question, which is such a good one, I really think because when we think about what are all the protective factors? What are all those things that have where kids come into the world and they develop like normal healthy digestion? It doesn't give them any problems, right? If they're having issues, something in that process has broken down, whether it's like ancestral flora that they're not inheriting because of C-sections, or now we're in like multiple generations of C-sections and multiple generations of lack of breastfeeding, whether it's that, whether it's early use of and frequent use of antibiotics, which is so common. We'll be like a broken record talking about that. And then these breakdown of sort of normal physiologic protective factors. I mean, a lot of kids are growing up in a super stressful world, much different than what we sort of evolved to grow up in a different stressors, I should say, much more chronic stress. And so I really do feel, whether it's as a result of, stress early in life or just health, issues early in life, or being born premature, or so many things that lead it to be that there can often be a digestive insufficiency piece, whether that's poor hydrochloric acid production, which I just saw your one of your newsletters came out with promoting what Dr. Sandberg-Lewis likes to teach, which is the Riddler point for HCl. Yes. I love a lot. So I do that one. We do. But I also think a lot about pancreatic function, and you mentioned that with the herbal bitters. We know, just like how what is it? Now I'm blanking on the enzyme that helps us conjugate our bile acids.
Glucuronidase.
Hemoglobin.
Oh,
glucuronidase. What am I thinking of? It'll come to me later. Enzymatic machinery is slow to start in childhood for some people. And I think about that also in terms of digestive enzymes. And so how can we support people's digestive enzyme process to come online? We'll use quite a lot of herbal bitters. I love, there's some companies that are making herbal bitters in apple cider vinegar, which is nice if you're worried about alcohol, or just, putting in hot water to help get some of the alcohol off. And then I also use quite a lot of pancreatinum 4CH, which is by an UNDA product, and it's actually homeopathic pancreas, and we'll use that to it's a 3 week on, 1 week off, 3 week on, 1 week off for 3 months, and that can sometimes feel like it jumpstarts their machinery. Because you're right, like kids, if it's the right placed remedy, it seems like it can. They're just such phenomenal responders. Often, not always. They're definitely those hard cases, but they're the ones that respond so well to those sorts of energetic remedies, in my opinion.
So just looking, that's true, very true, and I'm glad you mentioned pancreatic enzymes, and enzymes in general seem to be really helpful. Also, looping back to what you said about fecal retention, constipation. So, what are some of your favorite pediatric bowel movers?
I won't say magnesium. I feel like it's like everybody talks about magnesium, right? Because it's generally, it's not going to be mouth fermented. We're not going to get worsening bloating, blah, blah, blah. So I use a fair amount of magnesium. I have a lot of kids who come in on Miralax, and it's not my favorite thing to have kids on. And so I usually will try to get them off of it, but that's the thing that's working. And man, it's tasteless and it doesn't. And we can work on sort of bowel retraining while they're using that, and work on other digestive components while they're using that. I usually say, okay, but lots of magnesium. If I'm really thinking of a large intestine dysbiosis as contributing to malfermentation and bloating, I'll often use some of the fermentable fibers that we're really familiar with now, some of the prebiotic fibers. So whether that's, Heather's tummy fiber, the acacia fiber, or, using the partially hydrolyzed guar gum fibers, or some of the GOS fibers. I like Claire Labs, Lactomune. I know you guys have access a little bit more easily to the Bimuno products, right?
I've seen it on Amazon actually in America, but is there yeah, you can get it there. It has a little bit of lactose in it, but it's not. It should not be a problem even for those that are lactose intolerant.
Absolutely.
It's just minuscule, but but you mentioned another one by Claire Lab that has GOS in it, galacto-oligosaccharide.
Galactomune. Yeah, galactomune is what they call it. It comes in as a powder or capsules. Most of the kids, we're talking about kids generally.
Yeah.
According to the age spectrum, I usually see people starting around 3. I'm not a pediatrician, so I see kids usually around 3 and then up through their teen years. So we do a lot of powders, just because powders and liquids, because often kids aren't swallowing, but you'll be amazed some 4-year-olds are swallowing capsules. So that can be an easier way to get things in sometimes if kids are just really taste averse. So I do a lot of, we'll do some things in capsules as well. But those are really my go-tos. Magnesium and those fibers as an adult, starting super low with the dosing, just so we don't throw things into aggravation. So really using, an 1/8 of a teaspoon or less to start, and then just gradually inching them up. And that can just have such phenomenal benefits, not only for constipation, but maybe because of kind of shifting the microbial balance in a more positive direction.
And how do you see any other sort of very commonly associated issues with children and let's say, not just necessarily SIBO, but digestive disorders? Do you see if constipation and sort of tummy aches are the most common ones? Would you say that? Are there other ones, like, for example, I see a ton of leaky gut in my clinic, and oftentimes they don't know it, in terms of children. Their parents bring them in and I'm like, you can see the allergic shiners. You can just tell from a mile away that this child has some really activated immune response in their gut.
Yeah. Definitely rashes, definitely allergic shiners. I'm always looking for distended bellies, and a lot of parents won't even know that their kids are distended because it's kind of just been the norm of their lives, especially kids who had a lot of antibiotics early on. So I'll usually show them, like, this is a flat belly, this is a distended belly, so they can kind of start to track it a little bit more themselves. There's been some studies that actually looked at common symptoms that were predictive of SIBO in kids specifically out of Europe, and they looked at, there was, interestingly, in addition to what we talked about, abdominal pain, bloating, altered defecation pattern for sure. So definitely alternating diarrhea, constipation, or just straight up loose stools. Kids that just have loose stools with clear evidence of malabsorption, whether that's fat on the surface of the toilet bowl, or undigested food, really common, mucus. But in kids, interestingly, there can also be associated loss of appetite. That was something that was predictive for kids who just don't have a lot of appetite. And kids should have a great appetite. They're robust and vital and growing. They should really be eating kind of as much as they can. They're hard to keep up. So that loss of appetite is a real red flag for me, and it's usually associated with those kiddos who are having failure to thrive issues. And then belching and flatulence, just like in our adult population. And that was shown in the Polish study specifically to be predictive of SIBO in kids, is that association with belching and flatulence.
So let's talk about treatment in terms of SIBO in children. What's your go-to protocol with that?
So first off, as I think what all of us naturopaths might approach it this way, I really make sure that before we even dive into antimicrobials, that we've got the whole everything set for optimal digestive health. And so we kind of all the things that you and I have already talked about. So making sure these kids are using things to stimulate healthy digestion, whether that be herbal bitters or digestive enzymes, if it seems like they need them. That we've really exhausted the option of probiotics and prebiotic fibers, if that doesn't seem to be getting us all the way where we need to go. And really working on, especially in the more constipated kids, really working on how do we get them pooping regularly? So we might sort of like toilet time routines, making sure we're doing abdominal massage and, warm water and lots of physical activity and not a lot of sitting around and all of that kind of stuff. So that's where I'm going to go first before I really dive into treatment, because I want to make sure the treatment's successful and there's not relapse that happens. So I want to make sure that all the building blocks are in place. But once
can I interject? So just because I'm curious, so what do you tell the parents to just kind of monitor stool habits and sort of inspect the stool and just sort of keep track of it like that, and they do the abdominal massage, or because I know people are going to have some questions around that.
Yeah, so often I'm showing parents in the office how to do sort of your standard, right, along the colon abdominal massage. I'll often start, periumbilically and just work out in concentric circles, really following what we hope to be normal motility.
Clockwise.
Yeah, exactly. At that same time, I am also usually coaching on breath work with kids, because kids plus anxiety, no, their little guts are not going to work. We know that in adults too, but kids as well. And we live in a bit of an anxious world now. So I'm usually working on breath techniques. Great one is like put a little stuffed animal on their belly and have the stuffed animal rise. So they're learning how to do that diaphragmatic breathing. I'm usually also coaching like mindful eating. Like so many kids these days, just like adults, we're eating in front of our computers or on the go. Kids are eating in the back seat in their car seat, or they're eating in front of an iPad. Or some sort of tablet. And so really working on those, really doing education. That's often what I'm doing first. And then at the initial visit, also usually prescribing something to help with whatever I feel like is likely problematic, whether it's, I think that there is some digestive insufficiency, might be bitters or enzymes or something like that, or the pancreatinum 4-CH, or I might do working on bowel movement regularity and really working on that with them initially. And then if they do all those things and they come back and they say, still like really struggling. Oh, and I also at that initial visit, I start to ask them a little bit about you notice more or less symptoms with X, Y, or Z foods. And so I'll start talking about higher FODMAP foods and whether or not, are they eating dried mangoes every single day? A lot of kids eat a lot of dried fruit. So I'm like looking and I have them kind of track that. And so when we come back together, we can usually at that point say, great, it worked, awesome. We're like 90% there. Let's just keep going. Or we will say, well, maybe let's do some more investigation. And so at that point, we might do stool testing. At that point, we might do breath testing. I haven't had much success at under 3. 3 is about the youngest. Breath testing seems to work. And even at 3-year-olds, you're having to coach quite a lot with the breath testing. But we'll do that. And then we'll come back and we'll say, all right, let's review these results and come up with treatment. That was a long-winded around.
No, that was really good because, as practitioners, we're always looking for really helpful hints. And I liked the little clinical pearl there was the stuffed animal on the belly and while you're doing the breathing. I think that's really sweet. Yeah. And those kinds of things, I think, it just give more ideas to the practitioners rather than just like, well, they're bloated, therefore it's got to be SIBO. I know that's not what practitioners are doing, but it's sometimes, I think it's because we are more worried about the parents than about the child. The parent wants the result now, and
absolutely.
they're very anxious, and so you kind of have to work with that a little bit. So any tip like that is really...
That's such a good point, Caroline. I would say that that's something that parent education at first visit is far and away kind of the most important thing I focus on. And I talk a lot about, especially if they come in, let's say, thinking, my kid has SIBO. I had SIBO. I assume my kid had SIBO. Or I've read about this or listened to this podcast and, whatever. I think my kid has SIBO. What I often do is we'll educate them on, well, your kid might have SIBO. Awesome work. Like, awesome digging. Like, I can tell you're really advocating for your child there. And let's make sure there's not something else going on. Like, that's the big thing, right? Not just constipation, but also like the big baddies. I mean, I've had inflammatory bowel disease show up in little kiddos, right? That it wasn't on anybody's radar because they're so young. So let's rule out those things, and let's also just be really mindful before we dive into, do a testing that's going to result in antimicrobial treatment in kids who've already had usually a lot of exposure to antimicrobials. And before we dive into a treatment that's going to involve dietary modification, which is not my favorite thing to do with kids generally, let's really make sure we need to do that, right? And so I kind of just educate on that front first. And usually I can get parents on board, right? I can get parents on board to say, yeah, that sounds like a good plan. Because I also tell them, like, if it doesn't work, we're going to test, we're going to do it, we're going to test, we're going to treat. But I just want to be really honoring parents and really bringing them up to speed so they know they have all the information.
And it sounds like you're working sort of from the foundation upwards, in terms of rather than just, okay, we're going to start from the top down. So I really like that. Okay, so back to, let's say you have then tested that child for, let's say it's a 5-year-old child, patient has SIBO. What would you prescribe to that person, that child? Great.
5-year-old is perfect because that was one of my very first kid patients whose cases like burnt into my memory. Often what I'm doing, so I'm talking just like as I would talk with parents about what are our options for treatment. I do not use elemental diet when I work with kids. I know some practitioners that do, but I do not feel comfortable with that. I for a whole host of reasons we could talk about, but I just don't. I do, except in very sick kids, obviously, or kids who have altered anatomy or other reasons to be on an elemental diet, of course. There's always exceptions. I'll always talk about herbs and pharmaceuticals. Like here in the state of Washington, I can prescribe pharmaceuticals. So I definitely will talk about rifaximin as an option. We've got great studies on safety and efficacy in treatment of SIBO with rifaximin. So I'll talk through those options and dosing options and cost and all of that sort of stuff. And then we'll talk about herbs. And honestly, I'm really cautious about the herbs that I use in kiddos, not because I think that they can't handle them. I just want to do the most minimal doses needed, and not to, kids can have allergic reactions to nearly anything. I mean, especially if there's a leaky gut component, I want to be really cautious of that too. So I use a fair amount of biocidin in kids. I think it's easy. I think it generally is palatable.
I was going to ask you about that. Yeah, I was going to actually ask you specifically about biocidin. You get good results with that, with kids?
I do specifically in kids. I will be honest, I haven't seen the same response in adults. And I really wanted to, but maybe I haven't been using it long enough or right. But I really, in kids, I feel like, maybe it's something about them being just these phenomenal little responders, but I really do think that they respond well. Dosing needs to be longer. As we know with herbs generally, dosing needs to happen a little bit longer over time. So I'm usually doing, 6 to 8, sometimes 10, sometimes 12, depending kind of on how long I think this issue has been going on, dosing for kids. And especially if they're a longer dosing, often, especially if there's a yeast component, because those little guys just take so much longer, so much more time to die. So I'll do longer dosing for those folks. And
the biocidin doesn't really, do you add in another antimicrobial for the yeast, or do you rely on the biocidin?
I do. I've actually seen biocidin work in kids with yeast. I know people will disagree with me on that front, but I really have seen it work. Sometimes, of course, I'll throw in nystatin if I think that a kid with a real strong issue and I just need the pharmaceutical. We'll do that. We know it's generally safe. It's been studied in kids, so I don't feel concerned about that. Sometimes, very rarely, I'll do grapefruit seed extract, but again, I just don't think this is where it comes down to like our research availability in the pediatric population. It's just not there with herbs, and I don't want to be overly cautious and disregard the power of our medicine because it's so phenomenal. And when you're working with kids and they're very anxious parents, you really want to make sure you're putting forth a protocol that has some meat behind it, right? That you can point to and say, this product has been used by tons of practitioners for many, many years for a very long time and is generally seen as safe. So I use biocidin quite a lot. The dose, what I also like about it is that the dosing is so
I love
low.
that you can't beat that. Yeah.
Yeah. What is it? 1 to 2 drops per 10 pounds. Sorry, I don't like kilograms. 10 pounds of body weight divided in 2 to 3 doses per day. So sometimes in some kids, I recently prescribed it was like 1 drop 3 times a day or 2 drops 3 times a day. I mean, it's really low dose. So you can really get it into most kids.
Well, this is the thing where I feel like this is why I was so excited about also having you on the show, because of the Gastro ANP and like this emphasis on naturopathic gastroenterology, because we've talked about this for so many years, so many decades, where our medicine really starts in the gut, and we always talk about treat the gut first. And now with microbiome research and everything coming to the forefront, I think we are really positioned very well as naturopathic practitioners to also teach other practitioners and parents, etc., about how to really take care of the gut. Because I do see that everyone's microbiome is just getting a hammering, So I do see a lot of dysfunction as a result of microbiome. I mean, SIBO is a really specific condition, and that's why I really like your approach of you go with the least intervention, because very often, even if it is SIBO in a kid, it's, you can probably switch on proper digestion pretty quickly in that kid. And then the resulting SIBO should also resolve, because then you've really sort of fixed the upper gut defenses. So, but getting back to more specifics also with tummy aches and nausea, I do see some kids with nausea. What are some of what are the underlying issues there that you see with kids, and what are your favorite remedies there?
Yeah, nausea is a great one, and a really challenging one. Nausea, chronic vomiting, nausea, lots of belching. I always think about delays in gastric emptying when I'm thinking about kids with those issues, or hiatal hernia syndrome, honestly, or hiatal herniatic syndrome, where you have that pressure of the stomach up against the diaphragm, opening in the diaphragm, and you get that dysfunctional lower esophageal sphincter, the potential for stomach to actually herniate up into the thorax. Even just a little bit can contribute a lot to nausea, delays in gastric emptying, reflux, belching, all that sort of stuff. So I'm usually working with kids in those situations. I'm doing the hands-on techniques that you guys are going to be teaching later this year, which is
great. Tell me more about your success rate with that, because I really want people to know about this. That even nausea in kids can be corrected with a hiatal hernia syndrome maneuver.
Yeah, absolutely. Especially in your chronically constipated kids, I've seen that happen a lot, where they'll just be backed up. They won't feel good. They'll feel nauseous. We'll work on correcting the constipation. The nausea might get better, but may not go away completely. And just like how they're amazing responders to everything else, it works incredibly well. So I'll often do the hiatal hernia syndrome maneuver that Dr. Sandberg-Lewis taught me in my education at NCNM and through my residency. And it's easy. It takes 3 minutes, 5 minutes, 10 minutes, depending on the body. It's an awesome opportunity at the same time to educate about breathing, proper diaphragmatic breathing, and how not to strain, and thinking about other ways in which they're kind of putting undue pressure on their organs of their abdomen, and how they could be exacerbating the hiatal hernia syndrome or a true sliding hiatal hernia. And kids love being touched generally, right? Like they love that. All of us do, right? It's so appreciative that kind of, and you can really get a lot of kids, not all kids, obviously, some kids don't like to be touched, but a lot of kids too, kind of their defenses come down a little bit. It works really wonderfully with like the awkward preteen. They just get to like lay down and I'm doing something on their belly, and they kind of just get to like relax and breathe a little bit. I usually can get a little bit more out of them during that. So that works wonderfully. And then we always want to work on aftercare for that. And so aftercare after that hiatal hernia syndrome maneuver are heel drops every morning. So drinking a glass of water on an empty stomach and standing up on the tiptoes and coming down on the heels. The effort there being that the weight of the water in the stomach kind of act like a pendulum and just like pull the stomach down away from the diaphragm. And I've seen that work really wonderfully in kids with especially nausea just has no other good explanation.
That's a really good point. I never thought to actually use the heel drops in children that are nauseous. So thanks for that. I usually do that for people that have, had an upper endoscopy and basically have been diagnosed with a hiatal hernia and they know that they have it. But that's a really good point for kids with nausea. Duly noted. Very good.
I should also say that I use a lot of Iberogast in kids with nausea, just because to talk about a well-studied remedy in the pediatric population. We don't have a lot of herbs studied in peds, but that's one, or that herbal combination is one. And I use a fair amount of that when I'm working with kids, because especially if I think there's a delay in gastric emptying, and that's what's contributing to the nausea. We'll do that.
What do you think is causing that in kids? If we're seeing that so often, this gastroparesis really in children.
A lot of things. I mean, I think in some there's some amount of a stress component that can play a role in certain kids, but I think far and away more commonly is a post-viral or post-infectious gastroparesis. I mean, similarly to how we can see it in adults, where we get these delays in gastric emptying that come as a result, following an infection of some kind, and even sometimes infections that you wouldn't expect, some sort of herpes-based infection or something like that can really. I just had a kid not that long ago who had like mono-like symptoms, and he's had not documented gastroparesis because we decided to try Iberogast first, and it resolved it, but clearly all the symptoms, nausea, and just kind of like not able to eat, poor appetite, lots of belching. Iberogast totally solved it. It was after like a mono-like illness.
Mono is glandular fever for all you Aussies listening.
Yeah, or Epstein-Barr virus. And I can't quite recall if he had it truly diagnosed or if it was just sort of all the symptoms of, but it worked. That remedy can work wonderfully in those situations. So I think that is definitely a piece. And, hypochlorhydria can contribute to delays in gastric emptying. I mean, and it runs a spectrum, right? We don't have to have truly paralyzed stomach to have, some delays or even dysrhythmias of the stomach, where it's just not contracting and emptying appropriately, even if it's doing it, but just not quite right. So I found that both bitters and Iberogast work well for that.
Great. One of the sort of banes of practitioners' existence is eczema in children, I think. Or at least, it's one of those really, parents are heartbroken. They've tried a lot of different things. They're so worried. And like that is one condition I can say that when I first started out in my practice in Montana, and I saw, that was pretty much par for the course. You saw eczema, you saw asthma in children. And it was, I don't know if it's just me getting older, but it just seems like I have been seeing for the last probably 5 to 8 years, like when I see an eczema case in children, it's tougher to treat than it was back then. So I don't know if it's just me or if kids are more suppressed in a way. And that's the way I think. But have you, other than food allergies and working with leaky gut, what are some of your approaches with that? Because it's also something that we often see that has a connection to digestive disorders.
Yeah. Oh, absolutely. Hands down. I mean, that's the first place I look always. I am I'm really hesitant, and this is just going to maybe set me apart, or people can disagree with me on this, but I'm really cautious about making dietary recommendations to the pediatric population. Anything that's going to result in a more limited or more restricted diet for growing kids. There's a good study that came out not that long ago that showed that dietary-based interventions that required food restriction for chronic diseases in children, things like IBS and diabetes and cystic fibrosis, actually put them at greater risk for developing eating disorder later in life. And I know that we all do it with such phenomenal intentions, and parents do it with such phenomenal intentions, but I think we've got to be really cautious about it. So I often will actually put food sensitivities kind of on unless it's like so obvious. Every time I eat X, I get like I really will put it on the back burner, and I'll work on digestive health as the main focus. So I'll look on how do we optimize digestive health in all the ways we've already discussed. And then, of course, nutrient status, making sure vitamin D levels are adequate, EFAs are in the mix, and probiotics often can be really beneficial using specific strains or broad spectrum. Doesn't I've had good success with both. And I think that the clincher, though, for me is homeopathy. I really do. I luckily, being trained with Dr. Sandberg-Lewis, I was sold on homeopathy. He said the best thing happened from for doing a good job having me as a resident was that he got me to get into homeopathy. So I love it. And I really do think kids are, like I said, phenomenal responders, and homeopathy, the right remedy for them will work. And I've seen the right remedy, even as simple as a calc carb, being able to recognize, and that's what I focused on initially, like how do I recognize those common pediatric patterns? I have Dr. Perskew's, what's it called? Pediatric, put it on my bookshelf over here. So I'm looking,
the one with his two kids that are all like in colonial clothes or something, right? Yeah, that book, I have that book somewhere.
It's such a great one. It's so great because you can just, you can flip, there's great indexes in it. You can flip through and find the remedy. If you can recognize even like the top 5 constitutions in kids, they're so clear. Most of the time, not always, but like they present so clearly. They don't have those layers of like stuff you have to get through in adults. They're just their little carb or nat mirror or phosphorus selves just to show up in the office. So that is a go-to for me because I think that can really shift. Because when we talk about eczema, so often it is coming. It's like it's intergenerational. It's constitutional. It's coming in that allergic triad kind of. That we see so frequently, atopic triad. So I think that homeopathy plays a huge role in that for me. And then if I try all those things, I will look at food allergies and food sensitivities, and I'll look at, trials of this and that. But it's honestly one of the last things I go to these days.
Interesting. That really is surprising to me because, that's something I think of obviously with the atopic issues. I want to remove the offending food for just a period of time. I always make that very clear, or if I see very high levels of secretory IgA on the stool with no apparent infection, I think, okay, why is the immune system so activated, non-specifically activated? So I usually do see IgG and IgA in those children just to see if there's any obvious foods. And, I had those cases where it was a weird one. It was like blueberry or, and they were getting blueberries all the time. And that was just one example. Certainly, I'm not saying take out blueberries, but you can have that, yeah.
I'll come back to this because it's such a good point you're making, because it's not that I ignore diet completely. Like I'll look through, just like we're wanting to make sure everybody's eating whole foods, diverse diet. I don't want like monolithic diets in kids either. And so often they are, right? They have like 3 food groups. They're like cheese, like strawberries and bread, right? Like clearly like their body's probably reacting to something. So I'll often talk a little bit about that. And it's like, if there's something they're eating all day, every day, I'm like, let's take a break. Like, let's take a break, even just reducing the quantity, and let's try to boost these other foods. What I'm careful to do often is not, if the kid is young enough, right, adults can do that kind of for them, and the kids don't even really necessarily know, right, that it's happening for them. As they get older, I'm just really cautious about making that education so that both parents and kids hear it. Like, this is a temporary reduction or temporary avoidance. Just because I have that running at that study, especially, and what I've seen in kids running through my mind around that risk of disordered eating.
Very good point. We certainly see a lot of that in our practice, but maybe because we're also specializing. And so, we see those people that have already restricted themselves severely. So that's always a bit of a chore to get them back to normal eating. Okay, so sort of slowly moving towards wrapping it up, but I have like so many more questions because, like there are probably tons of things I should ask you that I'm not thinking of. So maybe, are there any sort of clinical pearls that you can throw our ways with children that you find is really very helpful, whether that's a remedy or a condition that you really think is overlooked by us or anything like that?
I think really important clinical pearls would be, I would just strongly encourage nobody to put a kiddo on a gluten-free diet without testing them for celiac disease first. I think we think about that with adults too. It's one of those issues that, if they respond well to a gluten-free diet and and they're off gluten, and they're like, no, we're never going back to gluten. Parents are like, no, we're never going back to gluten. They're never going to be able to do that challenge to see if they truly have celiac. And because we know it's so much more important that they're so careful around gluten if they have true celiac disease, I think that that's a really important clinical pearl, because they need to buy into the education before they hit those rebellious teenage years and they're like, give me all the pizza, right, or something, so that they really, really do know. Being just really cautious. Just like, I mean, I would say that for adults as well. Just always, always, always test people for celiac disease before you put them on a gluten-free diet.
And which one do you like? Which panel do you like? Like, do you just do serum levels?
I do serum. Yeah, I do serum, and I usually do. So I was lucky enough to have Lisa Shaver as my teacher for advanced gastroenterology, and she did an amazing celiac and non-celiac gluten sensitivity lectures. And so the top 5 tests that I'll generally run as a panel, which some folks will balk. I mean, it's a number of tests, but of course, tissue transglutaminase, IgA and IgG, as well as deaminated gliadin, IgA and IgG. Most labs are just calling that anti-gliadin these days, IgA and IgE, or IgA and IgG, excuse me, and then total IgA. I'll usually do all of those. Obviously, you're doing the total IgA just to make sure they don't have a selective IgA deficiency that would make it so that you would miss. And that's so frequent. I mean, how many times have we seen labs come through where somebody's only had a TTG IgA and they're like, oh, no, you don't have celiac. Or TTG IgA, and just assume that it's not, because they don't have the total, and they have, if they turn out to have selective IgA deficiency, that's a problem. And so always the IgGs and the IgAs, because, and this is what Dr. Shaver really talked about and informed us, it's more likely if 2, of those 4 antibodies, if 2 are positive and 3 are, like, you get more and more and more likely, but even if just 1 is positive, there's a small risk that they do indeed have celiac disease. And so it just is that much more important. Now, whether those parents end up deciding to go and attempt to get the gold standard diagnosis, that's a much longer conversation to have, via endoscopy with biopsy. That's a big intervention to have in a little one. But having that gold standard diagnosis, especially if the serology is a little borderline, I think is generally a good idea. But I'll usually have that conversation with them, or I will refer them to a gastroenterologist where they'll also have that conversation. And then if they do come back positive and they do have celiac disease, or you think there's celiac disease, don't be surprised. I had a case that where the serology was positive. They did the endoscopy. There was no villus atrophy. The Marsh score, which is what you rate those biopsies on, was like 0. I mean, it was just so low. There was like no changes in architecture yet. But this kid still has positive serology. So what do you do in that case? And the parents really wanted to say, nope, he doesn't have celiac disease, and just let go of that concern. But the reality is that he just might have developed the antibodies and is just pre-destruction, right? Destruction, like it's ramping up. And if he were to continue to eat gluten, eventually he would have villus atrophy and all the complications that result in that. So a random little tidbit, but it's just one of the things.
That's great. No, that's a really good tip, because I think a lot of us are guilty, myself included, of having had just the ease of putting people on a gluten-free diet. So no, that's a very good tip to save them the pain of having to reintroduce gluten for the purpose of testing if they're feeling so much better. So that's the point. It was really not to miss that opportunity that they've already been on gluten and to use that window there. That's a really good point. Didn't Dr. Shaver do a lecture for you guys on the Gastro ANP?
Not yet. We're actually going to be recording with her for both her celiac and her non-celiac, the non-celiac gluten sensitivity lecture is phenomenal. Her celiac one is too, but it's so informative. We're going to be doing that next. So it's part of our 2019 CE calendar through Gastro ANP. We'll be offering both of those lectures, which I'm super
That's great.
about.
So, and like, just so that I know, like, can anyone listen to those, like purchase the lectures, or is it just for Gastro ANP members?
At this point, it's just for Gastro ANP members. It's an exclusive benefit for members, and that's really just to encourage membership, but also to just keep our naturopathic approaches really be able to really focus these conversations on naturopathic approaches and make it a very doctor level and doctor focused.
Fantastic. Well, Dr. Taylor, it's been such a pleasure to talk to you today. Where can people find you? There's always tons of patients listening. And if somebody has a child that's not responding to whatever treatment that they're on, and where can they find you?
They can find the easiest way is just go to my website, which is Megan Taylor, MD, as in naturopathicdoctor.com. And there's all sorts of information on my practice. I practice and see patients, like you said, in Seattle, Washington. And I also do distance consulting online for folks that can't travel to see me, and just to do some basic sort of education pieces about specific cases. So that's the best place to find me. I've got some good resources and link to kind of all of everybody else's amazing resources too, working on building that. But that's the best way to reach me at this point.
Fabulous. And we'll have all of Dr. Taylor's contact details and web presence in the show notes. So, and I'm sure that there's going to be more conversation with Gastro ANP. I think it's such a great organization. I'm, of course, a member. And look forward to what you put together, and definitely interested in that track, that fellowship track. So thank you very much. And we'll see each other, I'm sure, again very soon at the SIBO conference next year in April. I'm sure you'll be there.
Absolutely.
It'll be in Seattle.
Yep.
All right. I'll see you then. And thanks again.
Thank you, bye.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.